Hi guys, just give me a thumbs up if I'm loud, clear, and visible to you. So welcome back to the Farre section. So we will be talking about some of the important questions from infectious diseases and the hematology. Well, first let me list what are the important topics from this so that you don't miss out anything, because given the time available, I will not be able to cover all the important questions from ID as well as hematology. But from infectious diseases, according to me, the most important topics are HIV, dengue, tuberculosis, malaria, and leptospirosis. Malaria and leptospirosis. Some of the universities have also seen frequently asking a long question on enteric fever. So as long as you cover these, you're kind of sorted for infectious diseases. And today I will be addressing two of them, HIV and dengue, from the infectious diseases. The remaining questions you can do from the Farre section of the MEDED. And from the hematology, of course, you know that anemia is the most frequently asked long question. So from hemat, mostly you can expect questions on anemia, clinical features, evaluation, management, and might be asking you to give a detailed description of a subtype, either iron deficiency anemia or B12 deficiency anemia. And then leukemias is likely to be a long question. Lymphomas are likely to be a long question. And leukemias, sometimes a specific subtype may be a long question, like AML, CML, ALL, or CLL. And lymphomas, you have the Hodgkin's lymphoma and non-Hodgkin's lymphoma. Any of them can be independently asked as long question. Okay. So today from the hematology section, we will concentrate on leukemias. We'll try to cover AML and CML. If time permits, we will go beyond that as well. Okay. But anyway, all these questions are there in the Farre section, and you can definitely go through the Farre section to cover whatever questions we're not able to address today. Okay. So let us first start with the infectious diseases, and the most important question from the infectious diseases is going to be on HIV. The structure of the question may go something like this. Write a short note on HIV and its complications, explain immune reconstitution inflammatory syndrome and current management of HIV. Okay. Now, the first point, many universities have started asking clinically oriented questions or a clinical STEM story, and then asking you to diagnose based on the story and then you elaborate further. So if the question is about the HIV, most likely, if it is clinically oriented, most likely it will go like this. A person with promiscuous behavior or high risk sexual behavior. Sometimes in the past, questions used to mention a particular profession. Of course, I do not want to comment about it now, but at least high risk promiscuous or high risk sexual behavior, or visit to commercial sexual workers, or IV drug abuser. That is how the story begins. After that, they may elaborate some symptoms pointing towards one of the opportunistic infection of HIV. So from there, you get to know that this is the question about HIV, and then you can elaborate further. Okay. So what is HIV? HIV is a virus, of course. It's a single-stranded RNA virus which belongs to the Retroviridae. What is the mode of transmission? There are several modes of transmission. Among the modes of transmission, the highest risk of acquiring HIV infection is through blood transfusion. Apart from that, it can also be transmitted through the sexual route, and we know that the most common route of transmission reported worldwide is through sexual contact with an infected individual. Apart from that, needle prick can also cause, but one should remember that the risk of transmission through solid needle prick is very less. So it is usually less than 0.3%. That means if 1,000 people get pricked by a needle which was already pricked to an HIV positive individual, 3 of them may turn positive. The remaining 997 do not get the HIV. So this is about the mode of transmission. Highest risk is with blood transfusion, sexual route, needle prick. We forgot to mention one more, the mother to child transmission. Mother to child transmission or parent to child transmission. So these are the modes of transmission for HIV. Now, when someone gets infected with HIV virus, what all clinical manifestations it can lead to? So, HIV has a natural course of illness. So, once there is an HIV infection, usually 2 to 3 weeks after acquiring the HIV virus, some patients, I'm not saying all the patients, usually less than 50% of patients develop something called as acute HIV syndrome. And another 50% or more patients will not develop any of them. So they directly go to become what we call as chronic HIV infection. So today, if I inoculate HIV virus in somebody, in a group of people, 50% or lesser than that will develop an acute illness. Remaining 50% don't develop any acute illness. They directly become chronically infected. Those who develop acute illness, we will call it as acute HIV syndrome. What is it? It's nothing but an acute febrile illness means, and just like how you get viral fever or enteric fever, this also looks like a febrile illness. When does it occur? Usually occurs 2 to 3 weeks after the infection, and quite rare after 1 month of acquiring the infection. So during this period, the HIV virus starts targeting the CD4 cells. So CD4 cells start going down during this period, and it's just 2 to 3 weeks after the infection. So body hasn't mounted an immune response yet, or a strong immune response is not mounted yet. So you don't detect any antibodies against the virus. Patient has got infection, virus is replicating, virus is targeting the CD4 cell, but you don't get any evidence on the conventional immunological studies. Body hasn't produced IgM antibodies yet, IgG antibodies yet. So if you go by any IgG or IgM antibody tests, they will turn negative. So then if I have to diagnose this in the acute phase, how can I diagnose? Only P24 antigen of the HIV may be detectable during this period. Okay, or you can also do the HIV PCR, which may be positive, but there will be no antibodies during this phase. Okay, and what are the clinical features of this acute HIV syndrome? It resembles infectious mononucleosis. Means in infectious mononucleosis, patients often have fever. They will have fever. Then they may have sore throat or throat pain. They may have tender lymph nodes, tender lymphadenopathy. And apart from that, a good number of the patients may develop a rash. So it is basically a fever with rash occurring in less than 50% of the patients. Remaining 50% of the patients, they don't get to know that they have got infected with the HIV. Okay. Now, regardless of whether they experienced an acute HIV syndrome or not, eventually all patients who got infected with HIV will enter into a chronic phase. Now, what happens in this chronic phase? In the chronic phase, serially, see, acute HIV syndrome, you had all this fever, lymphadenopathy and all, it all settles, right? And after that, it's a phase of quiet, means no other major symptoms are there. So during this period, majority of the patients are generally asymptomatic. So if patient did not have acute HIV syndrome and he has entered the chronic phase, he will not be even aware that he has got HIV virus in him. So majority of them are going to be asymptomatic. Some of them may have generalized lymphadenopathy. Because in the lymphoreticular system, the HIV viruses are replicating. So some of them may have generalized lymphadenopathy. But again, only if a doctor examines for the generalized lymphadenopathy, it will be detected. Otherwise, they may not have any evidence that they have got infected with HIV. But during this chronic phase, the antibody production would have started, and you can start doing the antibody tests to detect the HIV infection. But during this period, unknown to the patient, silently the CD4 count progressively decreases. And when the CD4 count goes catastrophically low, generally less than 200, patients develop significant opportunistic infections. And when the CD4 count goes less than 200 and patients develop major opportunistic infections that we call as AIDS defining illnesses like cryptococcal meningitis, then we will call that condition as an advanced HIV, or the yesterday's term called as AIDS. So where you will have CD4 count less than 200 or what we call as AIDS defining illnesses. So what is the natural course of HIV? HIV infection happens, then patient HIV starts incubating. Some patients may manifest with an acute febrile illness resembling infectious mononucleosis 2 to 3 weeks after the infection. Majority patients don't even manifest that. So whether you had an acute febrile illness or not, eventually enter into chronic phase. During this chronic phase, HIV starts replicating. So the HIV viral load goes on increasing. The CD4 cell count goes on decreasing. And when CD4 cell count becomes critically low, generally less than 200, you start seeing major opportunistic infections. And once that happens, we will call that as AIDS. So this is the natural progression of HIV. Now, what systemic manifestations HIV can produce? Because when we talk about HIV, we say it is the modern days great mimicker. It can mimic like various other disorders. That means it affects multiple organs, right? So what all organs get affected by HIV? I'm not only talking about opportunistic infections. HIV itself is organ toxic. Means HIV virus itself can cause damage to various organs apart from opportunistic infections. So when it comes to the cardiovascular system, HIV accelerates the atherogenesis. And because of this accelerated atherogenesis, and HIV also causes endothelial injury, there is increased risk of coronary artery disease. Coronary artery disease. So a lot of older generation HIV patients who did not develop major opportunistic infections still died early because of the coronary artery disease. In fact, the coronary artery disease is the most common serious complication of HIV. Means cardiovascular complication, the most common cardiovascular complication of HIV is going to be development of coronary artery disease, which is due to accelerated atherosclerosis. And it is also partly contributed by a side effect of various antiretroviral drugs which are known to cause dyslipidemia. What else it can cause? The HIV also causes HIV cardiomyopathy. So what is this? It's nothing but a form of dilated cardiomyopathy. So when we study about dilated cardiomyopathy, we study various causes like familial and all. And one of those causes is also HIV infection. And this dilated cardiomyopathy may lead to heart failure. Lead to heart failure. Okay. Now, will HIV affect the central nervous system? Yes. So HIV increases the risk of cryptococcal meningitis or fungal meningitis, in other words, you can say. And not just that, HIV also increases the risk of developing tuberculosis. So there is also, you can say, increased risk of TB meningitis. And apart from that, HIV virus is toxic to the neurons, and with progression of HIV and the viral replication, eventually the neurons start declining in number and you end up with what is called as, older times we used to call it as AIDS dementia complex, or today we call it as HIV encephalopathy. HIV encephalopathy. So HIV is affecting heart, it is affecting brain, and when it is affecting brain, it is causing severe dementia. Okay. Will HIV affect kidneys? Yes. It causes something called as HIV associated nephropathy. Associated nephropathy or HIVAN. So technically what is it? It is nothing but a form of focal segmental glomerulosclerosis, and it presents usually as nephrotic syndrome. It presents usually with nephrotic syndrome. Particularly more common in Africans infected with the HIV. Okay. What GIT manifestations I can expect in a patient with HIV? First of all, there is increased risk of oral and esophageal candidiasis, one of the very common complication of HIV. Increased risk of oral and esophageal candidiasis. And HIV is also known to cause something called as HIV enteropathy. So what is this? There is also increased risk of opportunistic GIT infections. Apart from that, there is something called as HIV enteropathy. So particularly these pathies you need to mention: HIV encephalopathy, HIV enteropathy, HIV cardiomyopathy. So what is this HIV enteropathy? It's a form of chronic intestinal inflammation without any other opportunistic infection, purely caused by HIV. And how these patients present? They present with chronic diarrhea. Yesterday we defined what is chronic diarrhea, right? What is chronic diarrhea? Diarrhea of more than 4 weeks with negative workup. What do I mean by negative workup? Means you have evaluated for underlying cause and everything turned out to be negative. Patient doesn't have tuberculosis, amoebiasis, or tropical sprue, or any of these common causes for chronic diarrhea, IBD, all of them are ruled out. Patient is HIV positive, he has chronic diarrhea, and we are not finding any cause. Then we call it as HIV enteropathy. Okay. Then skin. So more than 50% of HIV patients have seborrheic dermatitis. They have seborrheic dermatitis. And they also have T cell leukemias infiltrating the skin. So these are all common manifestations of organ involvement in HIV. This is a very brief list. It's not an extensive list. In a proper exam, if you are able to write these many, is more than enough. With the time available for you to write an answer sheet, this is more than enough. Okay. But I definitely also want you to write a small table mentioning important opportunistic infections, because CD4 count as declines, the risk of opportunistic infections goes on increasing. So what are the important opportunistic infections? Well, the first thing you have to mention here is the most common opportunistic infection in HIV. Most common opportunistic infection in HIV. So the Samantha, dermatitis herpetiformis, it's there in the name. It's dermatitis, means skin inflammation. Herpetiformis is called because you get those herpes-like lesions on the skin, means small vesicular and pustular lesions, which is usually encountered in patients with celiac disease. Okay, the most common opportunistic infection in HIV is tuberculosis. Okay. So first of all, seborrheic dermatitis, yes, it's a very common skin condition, but it is more frequently encountered in HIV patients. More than 50% of HIV, like I would say that many times when HIV patients walk into the OPD, especially those who are not yet started on the antiretroviral drugs, when they walk in the OPD itself, most of the doctors sense that there is something wrong with the patient, and that's related to the appearance, and partly that's because of the extensive seborrheic dermatitis, like face everywhere there is dermatitis and peeling. So it is more extensive in an HIV individual than a normal seborrheic dermatitis patients, but the only way you can differentiate is by testing for the HIV. Okay. So tuberculosis is the most common opportunistic infection in HIV patients. Okay. Now these opportunistic infections do correlate with the CD4 count. So when CD4 count is more than 500, the risk of opportunistic infection is very minimal. So they are prone to infections as much as a normal individual is prone. But once it drops below 500, tuberculosis starts, like the risk of tuberculosis increases. And when it is less than 200, especially the respiratory system gets affected by Pneumocystis jirovecii. We used to call it as the Pneumocystis carinii. So Pneumocystis jirovecii infection, GIT infection by Cryptosporidium, or oral candidiasis, or fungal pneumonias, including cryptococcal pneumonias, occur when the CD4 count is less than 200. But when it drops below 100, you can develop the CNS toxoplasmosis, then the esophageal candidiasis, or CMV esophagitis. And when it is below 50, you can develop the cytomegalovirus retinitis, cryptococcal meningitis, then infection by MAC or Mycobacterium avium complex, and even the primary CNS lymphoma associated with the Epstein-Barr virus. What are the important ones that your teachers are particularly looking for that you should remember? Tuberculosis, pneumocystis jirovecii, toxoplasmosis, Cryptococcal, Mycobacterium, avium complex, and CMV retinitis. These are the ones you need to remember and replicate in the exam. Okay. So now we have a fair idea about HIV, right? HIV is a single-stranded RNA virus which usually gets transmitted through blood transfusion, sexual route, or mother to child, or through needle prick. The risk is least with the needle prick. And once they get infected, they may go through, like initially 2 to 3 weeks later, they may get a short period of fever and lymphadenopathy, sore throat and rash, or they may not develop any of this, but they get into a stage called chronic phase where the virus keeps replicating, the CD4 cell progressively keeps going down. So during this period, only investigations can diagnose. They may not have any symptoms, or some of them may have generalized lymphadenopathy. When CD4 count critically drops, that is where the problem starts. They start developing opportunistic infections. So we have already covered what are organ manifestations to expect and what are the opportunistic infections to expect. Now, once you recognize that this individual is going through what we call as HIV, how are we going to manage? Well, the more the virus replicates, more the destruction of CD4 cells, more the destruction of CD4 cells, more the complications. It's as simple as that. So what is the best way? Of course, the best way to treat is to get rid of the virus completely from the body. As of now, the currently approved drugs are not able to achieve that. They can only suppress the virus to almost non-detectable levels, which itself is a great achievement of medical research. And if I'm able to suppress the viruses to bare minimum levels, non-detectable levels, then the CD4 cell destruction stops. And once the CD4 cell destruction stops, the immune system bounces back and the risk of all these opportunistic infections come down. So that's why we have to treat all HIV patients with antiretroviral drugs. When I was an MBBS student, there were some indications for starting ART. So all patients detected with HIV. So today, a lot of HIV patients get detected even with the acute HIV syndrome, because we could do P24 or HIV PCR. Remaining patients get detected in the chronic phase. So during my times, when we detect an HIV individual in the chronic phase, we were not directly starting with the antiretroviral drugs. So we used to wait for the CD4 count to drop below 200. But by that time, they would have already developed organ dysfunctions, or they would be at extreme risk of opportunistic infections, or they might have developed opportunistic infections. So today we don't wait for all those things to happen. The day you diagnose the case as HIV, you start antiretroviral drugs. And what is the currently recommended regimen? What is the currently recommended regimen? So NACO recommends TLD regimen. So you will have a single pill containing 3 drugs that they should take on a daily basis. 1 pill a day containing 3 drugs. So T stands for tenofovir disoproxil fumarate. Simple words we can write tenofovir or TDF. L stands for lamivudine. And D stands for dolutegravir. And since the advent of dolutegravir, the outcome of HIV patients has improved significantly. So this is one of the best treatment we could offer for the HIV patients, right? So this is the standard preferred regimen. We call it as single tablet regimen or STR, containing TLD, tenofovir, lamivudine and dolutegravir. Okay, but many times what happens is HIV patients, because by the time we detect, their CD4 count might have dropped below 500 and they might have developed a tuberculosis infection. So there comes the important question. What should I do if there is HIV TB co-infection? Should I start the ATT first or the ART first? The answer is ATT first. Why? So can anybody tell me why I am preferring to choose the ATT first instead of ART? Why not? Why not control the HIV infection first? Because there is risk of something called as IRIS. So what IRIS stands for is immune reconstitution, inflammatory syndrome. This can be so severe that sometimes it can be life threatening. This can be life threatening. So what exactly happens here? So let us say there is an HIV patient, right? I'm just giving you a hypothetical example. So someone got infected with HIV, he got into chronic phase, and during this phase, his CD4 count started declining. The HIV viral load started increasing because HIV is replicating like anything. And then one fine day, his CD4 has, let us say, dropped to, let us say, 100. Okay. And once his CD4 count is less than 100, he will certainly have opportunistic infections. And even before reaching the 100, he might have developed tuberculosis. So let us say he has developed pulmonary tuberculosis. If he was in India or Africa, definitely he would be exposed, or he was already having a latent TB infection. It gets reactivated once his CD4 count drops below 500. In this case, it's 100. So TB is definitely going to be reactivated. Now he has pulmonary TB. But this patient may not come to you with florid symptoms of TB. Why? Because most of the infections symptoms are related to inflammation. Like if I have meningitis, right, I will have headache, I will have nausea, vomiting, but they're related to inflammation of the meninges. But if my immune system is so weak that it cannot mount an inflammatory response, then all the inflammatory symptoms will be suppressed. I may have meningitis, but I may not have the headache and other symptoms. I may have some abscess, but I may not have fever. I may not have the redness and swelling of that site because my immune system is not able to mount an inflammatory response because it is that weak by the HIV infection. So the symptoms are masked, but still, okay, I diagnosed the HIV here and started ART. Once I start ART, what happens? The immune system starts reconstituting, right? Because the virus starts coming down, the CD4 count starts increasing, so immune system starts becoming stronger and stronger. And with that, we start seeing a strong inflammatory attack on all the sites where other opportunistic infections were there. So there will be worsening of the opportunistic infection symptoms. Like let us say I had cryptococcal meningitis. I wouldn't be probably having any meningeal inflammation. I have cryptococci causing the infection of the meninges, but signs of inflammation were not there. So there is no raised intracranial tension because meninges are not swollen. But once you start ART, immunity is bouncing back. It starts mounting inflammatory responses. Suddenly, meninges start getting inflamed, swollen, intracranial tension starts rising. Patient will start projectile vomiting, decreasing sensorium, and severe rise in intracranial tension may kill him. Similarly, pulmonary TB, I may not have any symptoms, but once you start ART, my immune system reconstitutes and strong inflammatory response. So now I may even present with ARDS because of an intense inflammatory attack. So once the immunity reconstitutes, the inflammatory attack on the infected organs worsens. This phenomenon is what we call as immune reconstitution inflammatory syndrome. And to avoid getting into this, the first thing you should do is first start to kill the opportunistic infections. If I have pneumocystis carinii pneumonia, first I should treat that. If I have, let us say, TB, I should treat that. And then start the ART so that I am saved from iris, right? So that's why we are starting the ATT first. And then we are starting the ART. And once I have started the ATT, after how many days of starting ATT, then I can start ART? That's a question. And that depends on the CD4 count. If the CD4 count is less than 50, then I can't wait too long because you may be able to avoid iris, but on the other hand, you are letting the virus replicate further and invite other opportunistic infections. So if CD4 count is less than 50, then within 2 weeks of starting ATT, I should start ART. But if CD4 count is more than 50, then maybe I can start after 2 months of starting the ATT, right? So iris, how do I manage iris? The iris can be managed by ATT first, if TB, then ART, treat opportunistic infections, first. And if life-threatening inflammation happens, you may consider giving steroids. You may consider giving steroids to suppress the inflammatory cascade. See, Sutapa, ART takes time to bring down the HIV. ART is not treating the opportunistic infection. See, remember here, you have opportunistic infection and HIV in your body. Okay. And your immune system. Your immune system, whenever there is an infection, should mount an inflammatory response. Its job is to mount an inflammatory response against opportunistic infections. Okay. But unfortunately, your immune system is weakened by the HIV. Your CD4 count was low. That's why it was not able to mount the inflammatory response. So now you have opportunistic infections without inflammation. But once you start ART, HIV starts coming down. And HIV starts coming down, the CD4 count starts increasing. Your immune system becomes strong. And it starts mounting the inflammatory response for the presence of opportunistic infections. But that inflammatory response is going to cause organ infections, inflammation. So if I cause meningeal inflammation suddenly, intracranial tension increases. So same happens at various organs. So if there is an opportunistic infection in any organ, there will be intense inflammatory response against that. And that intense inflammatory response cause organ dysfunction, because once organs are inflamed, like lungs inflamed, that is ARDS, they are going to become dysfunctional, hypoxia, they can lead to death. So that's why when we suspect that there is a possibility of iris, we first treat the opportunistic infection. So if there is no source for triggering the inflammation, then there won't be inflammation. So first clear the opportunistic infection, which is a source for triggering the inflammation, and then start treating the HIV, right? That's the approach. Okay, so after the HIV, now let's go to our next topic, which is going to be dengue. So HIV is definitely a very important question. Many universities have asked it as a long essay, but then depending on which season of the year the exam is being conducted, many universities give emphasis on the dengue as well. Particularly if the exam is conducted beyond April towards May, June, a lot of universities conducting exam there, they start asking questions on dengue, right? So the question may go like this. Write a short note on dengue, describe danger signs of dengue, and elaborate on monitoring and management of dengue. See, HIV is an important question for university, but for every doctor, dengue is an important question. Whether your university paper asks something about dengue or not, you will definitely face a dengue patient once you complete your MBBS and start internship or start practice. So you should know everything objectively about dengue, right? So just like HIV, our answer will have a similar structure. We will mention what is the causative agent. We know that it is dengue virus. There are 4 subtypes of dengue virus, which we will label as dengue virus 1, 2, 3, and 4. Usually abbreviated as DENV1, DENV2, dengue virus 3, and dengue virus 4. And its mode of transmission, it is vector borne. And what is the vector here? The Aedes aegypti mosquito is the vector. And we all know that it is common during rainy season. Why is it common during rainy season? Because of course, wherever there is mosquito breeding, the risk of having these Aedes aegypti mosquitoes, and thus the transmission of dengue also increases. So typically we see majority of the dengue outbreaks happening during the rainy season. Okay. Now when someone gets infected by this dengue virus through the mosquito bite, what all clinical manifestations it will lead to? So just like HIV, the dengue also has a natural course of the illness. So once you get Aedes aegypti mosquito bite, virus is instilled into our body. For first 7 to 10 days, you may not see any signs or symptoms because the virus is incubating. So the incubation period of dengue virus is around 7 to 10 days. So after this 7 to 10 days, just like how HIV patients got into an acute febrile illness, at least some of them, dengue also gets into an acute febrile illness. So from day 1 to day 4, the patients will develop fever. So during this phase, means day 1 to day 4, day 1 of symptom to day 4, it's called as febrile phase, where fever is the dominant symptom. Before that, it is incubation period for 7 to 10 days after the mosquito bite. So during this period, patients develop high grade fever, very often 102 to 104 degrees Celsius or sometimes even higher. Along with that, musculoskeletal pain. And because there is musculoskeletal pain, which is very severe, in the past we used to call it as breakbone fever, right? Your teachers, especially your elder teachers, like to hear this word breakbone fever. Breakbone fever. Okay. Apart from that, they may have abdominal pain and generalized malaise, nausea, vomiting. These are the common symptoms. So it resembles like any other acute febrile illness, right? At this stage, without investigations, you can't tell whether it is malaria, enteric fever, dengue, or any of the other infections. Okay. And this day 1 to 4 is not actually the major problem. Patients feel the symptoms are bothersome. So patients are really worried about this phase. But as a doctor, I'm worried about what happens after day 4. So day 4 later, like day 5 and day 6, sometimes day 7, this phase is called as critical phase. So what happens in this critical phase? In the critical phase, the platelet count starts dropping. So during the fever period, the platelet may not fluctuate much. A minimal drop may happen, but it's generally insignificant. When the fever starts settling down, that is where you start seeing a significant drop in platelet count. So platelet count starts decreasing in the critical phase. So day 4, day 5, day 6, day 7, this is a period where platelet count start dropping. Now, as a doctor, should I be worried about Sutapa, because the intensity of musculoskeletal pain is so severe that it feels like someone is breaking their bones. Well, this is what the books describe. I have seen at least 3 to 400 patients of dengue over last 10 years, and none of my patient was so much bothered about the bone pains or joint pains or musculoskeletal pain. They complain about pain, but I don't think like truly we should be calling it as breakbone fever, or maybe it was seen commonly in the past, but today we have readily available analgesics and patients take analgesics, so probably they do not experience that intense pain. But yeah, books mention, old teachers are particularly fond of this term breakbone fever. Okay, so in the critical phase, platelet count start dropping. As a doctor, should I be worried about it? The truth is that in whatever number of patients I have seen, I have no mortality in dengue cases. But yeah, I know friends, colleagues who lost dengue patients. Of course, it's not their mistake. I'm not saying that. But none of them, as far as I know, died because of the low platelet. They bled to death. It can happen, but it is rare. But the critical phase, deaths are very common. Then why does the death happen if it is not because of low platelet and bleeding? So in presence of dengue virus, in the critical phase, there is capillary injury. So fluid starts leaking from the capillaries to whatever spaces it can leak into the peritoneum, into the pericardium, into the pleural space. So we will call it a third spacing of fluid or fluid extravasation. So there will be capillary leak, and this capillary leak will lead to pleural effusion, ascites, even pericardial effusion. Okay, these effusions are also not a concern. But the problem is, as I start leaking fluid from the capillaries, what will happen to the circulating blood volume? I'm losing water from the blood, right? Because of these capillaries, they're leaking. So the circulating blood volume starts coming down. And because of this severe decrease in the circulating blood volume, patient can go into a state of shock. That is what you call as dengue shock syndrome. So majority of the dengue deaths happen because of dengue shock syndrome and not because of thrombocytopenia leading to bleeding. Because as long as platelet count is more than 10,000, the chances of bleeding is very less. Until and unless you have additional risk factors, nobody bleeds. In centers where I practice, we have never transfused platelets when the platelet count was more than 10,000. There are doctors and centers where they transfuse at higher platelet counts, 20,000, 30,000. But if I see no bleeding tendency and platelet count is 10,000 plus, we don't transfuse because that's what the national guidelines recommend. So we don't need 1 lakh platelet count for a normal individual who is going through dengue to prevent bleeding. 10,000 plus is more than enough. Yeah, if the patient is going for surgery, I need higher platelet count. But someone who is just hospitalized or staying at home, as long as platelet count is 10,000 plus, it is unlikely to be a reason for death. But this capillary leak leading to dengue shock syndrome is an important reason for death. So this capillary leak happens, and can I identify that this patient has started leaking the fluid from the capillaries? If you can do ultrasound to see the presence of pleural effusion, ascites, and pericardial effusion, you already know that leaking of fluid from the capillary is happening. But then how easily it is available? In metros, major cities, it is available, but in small, remote places, ultrasound may not be feasible for you to do it every 2 hours, 4 hours in a patient to see whether capillary injury has started or not. So then can I predict the capillary leak happening? Yes. So as the water starts leaving the blood through capillaries, what will happen? The concentration of the blood starts increasing, and that I can easily monitor through what we call as hematocrit. So we start seeing increasing hematocrit, and that's why monitoring hematocrit is very, very important when you are monitoring a patient of dengue. More important than monitoring the platelet count, because if you see hematocrit has jumped more than 20% from the previous value or the baseline value, you know that significant hemo concentration has happened, significant plasma leak has happened through the capillary dysfunction. So you need to give them adequate fluid resuscitation. If you do not give sufficient fluids, they will get into dengue shock syndrome and you may end up losing them. Okay, so during this critical phase, you also start noticing that the liver may start becoming little dysfunctional. So that you may have increase in liver enzymes, that is SGOT and SGPT. Now after this, if during this period patient does not die, platelet count does not lead to a critical low value and he doesn't bleed and die, or he doesn't get into dengue shock syndrome and die, then recovery starts. So the recovery phase may last for 3 to 7 days. During this period, the platelet count starts improving, hematocrit stabilizes, patient symptoms resolve, he starts feeling well, he starts tolerating food, he is no longer nauseated, he is no longer bothered by pain. And then eventually the platelet count will normalize, hematocrit will normalize, and the normalcy is re-established. This is the natural course of illness of dengue. So the most important period is day 4 to day 6 or day 7. That is the critical phase where platelets drop, hematocrit rise because of the capillary leak. Okay, so the same thing that we have discussed, I have put a small graph for you to replicate. So as the graph says, the days of illness and the symptoms. So temperature, usually fever is high grade in first 4 days. That's the febrile phase. After that, fever settles. Sometimes there may be a bounce back of fever, but most patients remain fever free after first 4 days of fever. So in the first 4 days, maybe dehydration is a potential clinical issue, but nothing beyond that. But during the critical phase, shock risk is high. And if the platelets drop, bleeding risk is high. And just like I mentioned, if patient goes into shock, they may get into acute kidney injury, the pre-renal type, right? They may also have ischemic hepatitis, liver dysfunction, rising enzymes. Those things are expected. And if the critical phase is over, that is day 5, 6, or sometimes 7, then the recovery starts. But in the recovery phase, there is a possibility of complication, which is one of the common mistakes done by doctors per se. What is it? So during the critical phase, because of the capillary injury, the fluid has left the blood vessels and gone into the tissues, right? Pericardial space, peritoneal space, pleural space, third spacing of fluids. During this period, because the blood volume is down, we are giving fluids. But once you recognize that the recovery has started, you have to cut down or stop giving the fluids. Why? Because during the recovery period, the reabsorption of fluid happens. The fluid which has leaked into all these spaces starts coming back to the blood. So the blood volume will start rising. And if I also keep giving external fluids, I will expand the blood volume so much that I will cause fluid overload. Patient may develop pulmonary edema. So that's why we have to be very cautious in giving fluids after the critical phase. So on day 6, 7, 8, we need to be watchful of the patient's fluid parameters. With respect to laboratory changes, the platelet count start dropping after the febrile phase, remains low, may reach a very low level during the critical phase, and then eventually starts rising during the recovery phase. And because capillary leak happens in the critical phase, the hematocrit starts rising in the critical phase and then gets normalized during the recovery phase. Now, with respect to the serological studies, during the febrile phase, the first 4 days, the dengue virus is replicating like anything, but then body isn't mounting an immune response yet. It takes some time. So you don't detect the dengue antibodies in the first 4 days. If you want to detect, you have to detect the dengue virus antigen, that is NS1. But after 4 days, you start detecting the antibodies. The initial antibody is going to be IgM, eventually IgG. So IgM always indicates the acute dengue infection. IgG may be pointing towards past dengue infection, right? So this is about the natural course of dengue illness. Now comes the real part. Objectively, what your teachers are looking for if there is a question on dengue. They want you to mention differences between dengue fever, dengue hemorrhagic fever, and dengue shock syndrome. 3 terms. They are all not same. Dengue fever is like any case who has been infected with dengue, who has fever of 2 to 7 days duration, and has any 2 of the following manifestation. That includes headache, retroorbital pain, muscle pain, or joint pain. But there should be no evidence of plasma leakage. If there is evidence of plasma leakage through capillary injury, then we will start considering it as dengue hemorrhagic fever. Okay. And how do we recognize that? There is no rise in hematocrit by more than 20%. The rise may be less than 20%. Okay. There is no pleural or pericardial effusion or ascites. Then you can say that there is no plasma leakage. Patient has been infected with dengue, is getting fever and symptoms related to that, but there is no plasma leakage. Then we will call it as dengue fever. Now, if a patient of dengue fever has hemorrhagic tendency, what do you mean by hemorrhagic tendency? You have developed petechiae or ecchymosis, gum bleeds, or any active bleed. Along with that, you have also developed thrombocytopenia, that platelet count is low. Platelet count is decreased. And you have the evidence of plasma leakage. What is the evidence of plasma leakage? Increase in hematocrit by more than or equal to 20%. So what was the previous baseline value? Over and above that, the hematocrit is increased by more than or equal to 20%. Or patient has developed clinically significant pleural or pericardial effusion or ascites. Mild pleural effusion, pericardial effusion, and ascites are common. Clinically significant values encountered, then there is evidence of plasma leakage. So let me summarize what you should remember, because of course objectively you can't remember all the words that I'm mentioning here. So dengue fever is just fever and related symptoms, no evidence of plasma leakage. What is dengue hemorrhagic fever? Hemorrhagic tendency is there in the name itself. So dengue hemorrhagic fever refers to a patient with dengue fever, but additionally he has tendency to bleed in the form of petechiae, ecchymosis, gum bleeds and all. Platelet count is low, and there is also evidence of plasma leakage. Okay. The next entity is called as dengue shock syndrome. So what is dengue shock syndrome? Dengue shock syndrome is nothing but a dengue hemorrhagic fever. That means dengue fever with evidence of plasma leakage and thrombocytopenia, who has now gotten into a state of circulatory failure or shock. Now the shock definition here is clinical, because the WHO had to create definitions which are applicable to resource limited countries. Then sitting in Nigeria, if I have to diagnose dengue shock syndrome, right, I can't diagnose it by measuring the plasma lactate values and all. Not possible. So that's why it's very simple clinical. So any patient with dengue hemorrhagic fever, if he has weak rapid pulse, means what we call as steady pulse, very weak, difficult to palpate pulse with increased rate, or the pulse pressure. What is pulse pressure? Difference between systolic and diastolic pressure less than 20 millimeters of mercury, or evidence of hypotension, or even if I can't look at that, even cold, clammy skin, or patient being restless, we will count this as a dengue shock syndrome. Particularly, a tip from a practicing physician that I want all the MBBS students to know: if you see a dengue patient with restlessness, count it as a red flag sign. In fact, I can give you an example that I had a junior colleague who had just completed his post graduation and started the practice along with me in a hospital. And during the rounds, we were chit chatting, and he was standing next to a patient, and the patient was a bit restless. And he asked me, like we were talking about, I asked him, "What is this case, man? Looks a little restless." He says it's some fever and abdominal pain. That was a season of dengue. Bangalore was going through outbreaks of dengue. So I just told him, like, if he's dengue and restless, man, it looks bad, man. So he's like, yeah. I told him, just call the attenders and counsel about all possible negative outcomes, because he's quite restless and that's not a good sign, because he has just got admitted. We don't know his platelet count, his hematocrit and all, but once we monitor, I'm very sure if you're so restless, the hematocrit will be rising, his platelet count will be dropping, and that's what eventually turned out to be. Unfortunately, that fellow gotten into the dengue shock syndrome and lucky enough to survive with the resuscitation and medical management. But if that restlessness was not taken seriously and ignored and just treated like any other simple dengue fever, there could be a possibility of mortality, and my colleague would have also gotten into trouble with the family. So please remember, you see any patient with dengue who is restless, take it as a serious case. Even if the current BP is fair, even if everything appears good, take it as quite a serious case. Okay. So this is about the case definitions. What is dengue fever? What is dengue hemorrhagic fever? And what is dengue shock syndrome? Okay, now that I have recognized the dengue, how are we going to manage? So when it comes to the, I forgot to talk about the diagnosis itself. So first let us address the diagnosis. So if clinical symptom wise, especially rainy season, lot of dengue patients reporting in the hospital, and I got one more patient with fever. Dengue is always a suspicion. I have to investigate. So in the first 4 days, that is the febrile period, body wouldn't be mounting an immune response. So IgM, IgG will be negative. So during this period, you can test for the dengue antigen. NS1 antigen. NS stands for non-structural. So dengue has some structural and non-structural proteins. So we are looking for the presence of this non-structural protein 1 or NS1. Now after 4 days, we can go for the dengue serology. Dengue serology, looking for IgM and IgG antibodies. And as we know, IgM always indicates acute infection. If IgM is negative and only IgG is positive, it may be pointing towards a past infection. If both are positive, it's again acute infection. But if only IgG is positive, it is pointing towards a past infection. Once you're diagnosed that this is a case of dengue, how are we going to manage it? So for management, the first thing is you need to monitor. See, dengue virus is not directly killing the individual. It is our own body's immune responses which are causing the inflammation of the capillaries, capillary leak, and loss of fluid is responsible for majority of the patient's death. So we don't give any antivirals to the dengue. We will just try to manage our own system. And the main worry is about patient getting into the dengue hemorrhagic fever or dengue shock syndrome and dying. So I need to monitor the possibility of this patient progressing. So please monitor. Two things you need to monitor: the platelet count and hematocrit or PCV. We have to monitor them serially. Means not one value, like, okay, patient got with fever and I checked hematocrit, right now it appears fine, platelet count appears fine. No, you have to serially monitor hematocrit and platelet count to see the trend. Okay, and if hematocrit is rising and if it has gone beyond to 20% above the previous value, then you know that there is significant capillary leak happened. You need to have good fluid resuscitation for that patient to prevent shock happening in them. IV fluids are considered as the mainstay of treatment that reduces the mortality. Mainstay of treatment that reduces the mortality. If you use IV fluids judiciously, when required, give aggressively, when not required, withdraw, you will save the patients. Okay. Then third comes, okay, we are managing IV fluids and we are guided by hematocrit. If hematocrit is rising, once I start giving IV fluids, it should start coming down. So then I know that IV fluids are adequate. Next is platelet transfusion. When should I transfuse? Less than 10,000 platelet count, less than 10,000, prophylactic transfusion. Means if the platelet count is less than 10,000, the chances of spontaneous bleeding is there, so then transfuse prophylactically. But if platelet count is more than 10,000, you don't have to transfuse prophylactically. Then you should transfuse only if there is bleeding. And spontaneously bleeding is unlikely to happen when the platelet count is more than 10,000. But if there is trauma or other risk factors, they may be bleeding, transfuse. So the rule is simple. If a patient is bleeding and he has low platelet count, regardless of platelet count, transfuse. But if the patient is not bleeding, then as long as platelet count is more than 10,000, do not consider the transfusion, right? So this is about the dengue. So the dengue management is simple. It's all about IV fluids and platelet transfusion if required. Okay. Now let's go to the hematology part. I told you sometimes some universities ask about so-called red flag signs in dengue. Means what are the signs that you need to monitor in dengue which are pointing towards things not going well for the patient or pointing towards patient going into hemorrhagic fever or dengue shock syndrome. So the first one is rising hematocrit. Rising hematocrit. And I won't emphasize more. By now you should know that restlessness in a patient is a very bad sign. Okay. Then third, hypotension. Fourth, severe abdominal pain. And fifth, bleeding. So these are considered as the red flag sign. Okay. So that completes our discussion on the dengue. So apart from these two infections, I also want you to go through the Farre section on the Meded app, which covers other important infections like tuberculosis, malaria, leptospirosis. Okay. Now let me take you through the hematology. Hematology, according to me, these are the important questions that are going to come as long essays. Anemia, leukemias, and lymphomas. With the available time, I will try to cover the leukemias with an emphasis on the AML and CML. But I will give you a table which covers all the leukemias, and as long as you are able to remember this table, and you should be able to answer the questions coming from any of the leukemia, right? So let us start with the basic understanding of leukemias. Okay, the question may go like this: define leukemias, classify leukemias, and discuss about the clinical features of AML and CML, and write briefly on their management. Okay, so what are leukemias? I know most of you know that it is blood cancer, right? This much we already know. But then what are the differences between these terms, lymphomas and leukemias? And within that, we have AML, ALL, CML, CLL in leukemias, and we have Hodgkin's and non-Hodgkin's in lymphoma. So what are the technical differences between them? Okay, so before defining leukemias, let us understand all these blood cancers or hematological malignancies. How are they classified? the classification of hematological malignancies or blood cancers depends on the origin of those cancer. Where is that cancer originating? Because when we talk about blood cells are first formed in the bone marrow. They go through phases and then eventually they become mature cells, mature RBCs, WBCs, right? And then they are released into the peripheral circulation. So what we get in peripheral circulation is mainly mature cells. But if I look into the bone marrow, I will have some mature cells which are to be released to the peripheral circulation and plenty of the stem cells which have to go through the maturation to become final mature cells. Right? You can call them as immature cells or blasts, myeloblast, lymphoblast. So whether the origin of this cancer happens from the immature cells, that means inside the bone marrow, or whether it happens from the mature cells, that means outside the bone marrow. That is the basis for classifying. So if the origin of the cancer is inside the bone marrow, that means it is originating from hematopoietic stem cells. Hematopoietic stem cells. Or in other words, immature cells or precursors of the blood cells. Then we will call them as leukemias. We will call them as leukemias. Okay, and if the blood cancer originates from the mature cells are present in the lymphoreticular system, means lymph nodes, blood, liver, spleen. So if they originate, that means they are originating from mature cells. Then we will call it as lymphomas. Then we will call it as lymphomas. So when you talk about Hodgkin's, non-Hodgkin's, B lymphoma, T cell lymphomas, these are originating from mature B lymphocytes or mature T lymphocytes. But if a cancer originates from the lymphoblasts, means immature cells, it is originating in the bone marrow, then we will call it as leukemia. And depending on which progenitor cell is leading to development of cancer, we will classify them. If it is originating from myeloblasts, then we will call it as myelogenous leukemias. And if they are originating from lymphoblasts, then we will call it as lymphogenous leukemias. And myeloblastic leukemias can be of two types: acute myeloblastic leukemia and chronic myeloblastic leukemia. Similarly, lymphoblastic leukemia can be of acute lymphoblastic leukemia and CLL, chronic. Okay, how do I differentiate between acute and chronic? Simple. The patient is likely to develop acute florid manifestations, significant severe manifestations, if there is too rapid proliferation of these blasts. And if there is too rapid proliferation, the amount of blast cells will be more. If there is slow proliferation, the amount of blast cells will be less. So the percentage of blasts in the bone marrow is a deciding factor whether I will call it as acute or chronic. So if the number of blasts is more than 20%, let us say there is a cancer originating in the bone marrow and it is originating from myeloid lineage, myeloblasts. And when I look at the bone marrow biopsy, more among overall cells present, more than 20% are myeloblast. So if the blast percentage is more than 20%, then it is AML. But if the blast percentage is generally less than 20%, then it is CML. Same applies to the ALL as well. So if the blasts are more than 20%, it is ALL. And if the blasts are less than 20%, but it is lymphoblast, then it is CLL. So you're getting the point. The blood cancers are classified into lymphomas and leukemias. Lymphomas originate in the periphery from the mature blood cells. Leukemias originate in the bone marrow from the precursor cells or the stem cells, what we call as blast cells. If they are originating from the myeloid lineage or the myeloblast, then it is either AML or CML, depending on how much percentage blasts are there. More than 20% acute, less than 20% chronic. Same applies to the lymphoblast. More than 20% blasts ALL, less than 20% CLL. Okay, I hope this clarity we have. And then lymphomas, we have further classified them into, as we know, Hodgkin's lymphoma and non-Hodgkin's lymphoma. Okay. I definitely want you to read about Hodgkin's and non-Hodgkin's as well. It is there in the methods for a note section. You can quickly glance through and you should be able to write. So today I'll give you just how we can write questions on AML and CML. Okay. So AML is what then? AML is a blood cancer. So when you have to define, how will you define? AML is a hematological malignancy originating. It's a leukemia, right? It's a hematological malignancy originating in the bone marrow from myeloid precursor cells or myeloblasts. What problems it will lead to? The myeloid blast will start replicating in large number, and when they're not going to mature, they fail to mature, they don't become mature myeloid cells in the final part. So they are just replicating in premature form and large numbers, but they fail to mature. So what will happen? These cells start accumulating where? In the bone marrow, and when bone marrow is full, they'll also like spill over to the peripheral circulation. They go to different tissues, they start accumulating in the tissues. So what problems they are going to cause? One, at the level of marrow. Second, because of the tissue infiltration. So what will happen to the marrow? If all these premature myeloid cells start accumulating in the marrow, the mature cells, we are not maturing them, so the number of mature cells starts coming down. And because of the marrow infiltration, even the space available for other marrow cells to proliferate is all compromised, because all of that is being taken by these cancerous cells. So because of that, you end up with pancytopenia. What do I mean by that? All the three cell lines that we see in the peripheral blood is going to decrease, because the bone marrow, the production factory is all occupied by these myeloblasts. So you will have anemia or decreased RBC count, right? Then you will have decreased WBC count, and you will also have thrombocytopenia. And all of these manifestations can lead to their own clinical consequences. Anemia can lead to fatigue, heart failure, pallor. Decreased WBC count can increase the risk of developing infections. Thrombocytopenia can increase the risk of bleeding. Okay. Apart from that, these myeloblasts from the marrow, they are coming to the blood and they are reaching different tissues and they are infiltrating tissues. So tissue infiltration can lead to various manifestations. One of the manifestations which is typically asked as an MCQ as well is that these patients, when these myeloblasts infiltrate the gum, they can cause gum hypertrophy. Gum hypertrophy. And when these myeloblasts, or not just myeloblasts, when blast cells, even in like lymphoid leukemias, when the blast cells accumulate in a tissue like a tumor, like let us say they come to the skin and they all collect there and it appears like a tumor, that tumor like presentation of a conglomeration or a collection of blast cells, we call it as chloromas. So they may end up with chloromas. Chloromas are nothing but aggregation of blast cells in various tissues. Wherever some tissue has an aggregation of blast cells, that will be called as a chloroma. So what all AML is leading to? It is causing the failure of the marrow because it is taking up all the space available in the marrow. Second, it is coming to tissues and depositing here. It is causing gum hypertrophy and chloromas. Like you see in this picture, this patient is a classical case of AML who has developed gum hypertrophy. Okay. Apart from that, all these premature cells, they will also die. Means they will keep replicating, but they will also die. But when they die, they leak the content of the plasma into the blood. I mean, content of the cytoplasm into the blood. And their cytoplasm is high in potassium and uric acid. All of that gets leaked into the plasma. So the plasma level of potassium increases, uric acid increases. And we will call this as, so you can have hyperuricemia, hyperkalemia, and you may sometimes have hypocalcemia. And collectively, these manifestations can be called as tumor lysis syndrome. Tumor lysis, because these symptoms are coming because of the lysis of these tumor cells, so breakdown of cancer cells. It could happen naturally because of the cancer cells dying, or sometimes it can also happen because of chemotherapy. Because I give some chemotherapy medication, they will kill the cancer cells, leaking high amount of uric acid, potassium into the blood, giving rise to so-called tumor lysis syndrome. So these are the manifestations we are expecting because of AML. Marrow failure and related consequences, infiltration of blast into the tissues, and the death of blast cells, leaking uric acid, potassium into the blood, causing tumor lysis syndrome. Okay. So now if I'm suspecting it as a case of AML, potential clues could be the pancytopenia. So when we talk about pancytopenia, we have some number of causes. So as we keep ruling in, eventually we may come to the conclusion that this could be AML. Gum hypertrophy is again a good clue. So if you see chloromas anywhere, that's a good clue. Now you want to confirm it. So how will I establish the diagnosis of AML? So if you do peripheral smear, you may get pancytopenia, but apart from the pancytopenia, you will see there is increased number of myeloblasts. Increased number of myeloblasts. In the periphery need not be 20% plus, but if it is 20% plus in the periphery, it's very sure that in the marrow it will be even more. So in that case, it's anyway, you know, it is AML. So increased myeloblast, and some of these myeloblasts, particularly in some variants of AML, will have azurophilic needle-like inclusions in the blast cells called as R rods. So if R rods are seen, it is highly diagnostic of this needle-like inclusion that you see here is called as R rods. So this is what your teachers are particularly looking for in your answer. You should be able to mention R rods. Okay. Then if I do bone marrow, what are the findings I'm going to get? Now you only tell me, bone marrow will be hypercellular or hypocellular. I have pancytopenia in the blood. In the blood, all the three cell lines are decreased because the precursors of those cell lines in the bone marrow are dying because all these blasts are taking up the space. But because blasts are there, the bone marrow will not be hypocellular. It will be hypercellular. Hypercellular. The number of cells in the marrow is increased because all these cancer cells are replicating. Hypercellular marrow with more than 20% myeloblasts. More than 20% myeloblasts. Okay. Apart from that, we are in the era of more advanced diagnostics. So you can also look for cytogenetic abnormalities like translocation between 821 or inversion of 16 or translocation between 15 and 17. And there are also molecular studies identifying mutations responsible for development of AML like FLT3 mutation and NPM1 mutation. Not important for you to write in your prof exam, but this is an important MCQ per se. This is the most common. NPM1 mutation is the most common mutation in AML. It's a new field per se because now we have targeted treatments available for different mutations. At a UG prof level, you don't have to comment about it. As long as you're able to mention that in the bone marrow, the marrow is going to be hypercellular with more than 20% myeloblasts. And the myeloblasts may show what we call as R rods. Your teachers are more than pleased and they will move forward to the remaining part of AML, that is about management. Okay. Now, when it comes to the management of AML, it's an acute hematological malignancy. So first thing is all these myeloblasts which are taking up the space in the marrow and stopping the other marrow cell lines from growing, and then they're infiltrating the tissues and causing the tissue damage. The first thing is I have to bring down the number of blasts that are there in the body right now so that all these complications come down. And after that, the relapse rate is very high. So I need to make sure that the relapse does not happen. So that's why the treatment will be divided into two phases. Initial induction phase where we want to destroy these cancerous blast cells. And after that, a consolidation regimens where we are trying to prevent the relapse of this cancer. So what we can use for this induction regimen? So there is something called as 7:3 CD regimen. What does it stands for? So we give the treatment for 7 days. So day 1 to day 7. So in that, for all the 7 days, the C here stands for cytarabine. So for all the 7 days, we are giving this patient an infusion of cytarabine. So from day 1 to day 7, he is getting daily infusion of cytarabine. But From day 1 to day 3 also he gets an additional drug that is going to be daunorubicin or doxorubicin. So this regimen is what we call as 7-3-CD regimen. So 7 days of cytarabine, 3 days of daunorubicin. So first 3 days he gets both cytarabine and daunorubicin or doxorubicin, but the remaining 4 days, means day 4, 5, 6 and 7, he only gets cytarabine. This regimen is what we call as induction regimen. This like literally destroys most of the blasts. So now the patient's symptoms improve, bone marrow functions will start improving, but the chance of relapse is there. So we have to prevent that relapse. So whatever treatment we give for prevention of relapse, we will call it as consolidation regimen. Consolidation regimen. So what I can do here, either you can continue cytarabine for a long period of time. This is now considered as the first line treatment. But if feasible, you can also go for the bone marrow transplantation or hematopoietic stem cell transplantation. Bone marrow transplantation, more technical term is hematopoietic stem cell transplantation. This is considered as the second line treatment. So one of them can be offered to prevent the relapse of AML, right? So let me quickly summarize what we have discussed. AML is a leukemia, means it is originating inside the bone marrow. And as the name says, M means myeloid. So it is a myeloid leukemia with more than 20% blasts in the bone marrow. And because of this increased number of blasts, bone marrow failure happens and blasts infiltrate the tissues, giving rise to gum hypertrophy and chloromas. And if the blast cells die, they will release their intercellular components, causing hyperuremia and hyperkalemia. Now, if I have to establish diagnosis, I have to go for the bone marrow biopsy, where I will get hypercellular marrow with more than 20% myeloblasts. Pathologist, if required, they will try to identify CD markers for the myeloblasts to ensure that what they are seeing as increased in numbers are indeed myeloblasts. What examiners are looking for? You mentioned that it's hypercellular marrow with more than 20% myeloblast with Auer rods. Now, when it comes to the management, we follow an induction regimen and a consolidation regimen. Induction regimen is 7-3-CD. So 7 days of cytarabine, 3 days of doxorubicin or daunorubicin. And consolidation is with just cytarabine or bone marrow transplantation. But there is one extra point I want you to write. There is a subtype of AML called as acute promyelocytic leukemia or APML or APML. So for that, you need not go for this induction regimen. Instead, you can use a drug called as all trans retinoic acid or ATRA. This is again more of an MCQ point. If you can write in a prof exam, good. If not, as long as you're able to write the induction and consolidation regimen, it's more than enough. Now, there is a subtype classification of AML, which at a final prof MBBS medicine, you're not expected to write, mostly from the pathology as well as in MCQs, they expect. During my time, we used to follow FAB classification. Now it is WHO. I'm just leaving a table here of that WHO classification. If you find time to remember it, go through it. Otherwise, you can skip it. Okay. Now let me take you through the next part, that is CML. AML is what? Acute leukemia of myeloblasts having more than 20% blasts. When the blasts are less than 20%, but they are myeloblasts, we will call it as CML. AML had various causes, like a lot of cytogenic abnormalities were contributory. Translocation between 821 or 1517 or inversion of chromosome 16, FLT3 mutation, NPM1 mutation. When it comes to CML, it's all about one cytogenetic abnormality. What is that? A reciprocal translocation between chromosome 9 and 22. And this reciprocal translocation leads to fusion of two genes, like components of chromosome 9 and 22 are fused to form what we call as a BCR-ABL fusion gene. When these genes fuse, they express, or there is increased production of tyrosine kinase. tyrosine kinase and acting through the RTKs or receptor tyrosine kinase. These are the receptors for tyrosine kinase. These tyrosine kinase will lead to suppression of apoptosis, and because of this there is increased proliferation of myeloblasts or myeloid precursor cells. So because of that, there is slowly accumulation of myeloblasts in their immature form. They fail to mature as such. So this is similar to AML, but the number of blasts will be less than 20%, right? And the reason for this is the reciprocal translocation between chromosomes 9 and 22, bringing BCR and ABL together and causing the BCR-ABL fusion gene, and this is what we call as Philadelphia chromosome. And that has resulted in increased activation of the tyrosine kinase, and that has resulted in increased proliferation of myeloblasts. A very, very important point to learn here. If I want to suppress the myeloblast proliferation, what should I do? I should block this tyrosine kinase. Tyrosine kinase, right? If I block the tyrosine kinase, then the proliferation of myeloblasts will come down. So that's why when we talk about treatment of CML, we use the tyrosine kinase antagonist or blockers. So see, if you have, if you have a case of AML or CML or anything, so if the patient's hemoglobin is less than 7, we might have to give for blood transfusion. Blood transfusion is not therapeutic. What we're talking about is bone marrow transplantation. We are not transfusing blood. We are doing the bone marrow transplantation. See, what bone marrow transplantation does is it instills normal, without genetic seed, no cytogenic, the precursor cells or hematopoietic stem cells with no cytogenic abnormalities. This patient had cytogenetic abnormalities which has resulted in development of AML, like those we mentioned here. These chromosomal anomalies or mutations were there in these patients' stem cells. That's why they were replicating uncontrollably. But if some healthy donor who does not have these cytogenetic abnormalities, if their marrow cells are transplanted, then this marrow will start producing cells which will mature finally. And anyway, we are giving the chemotherapy or immunosuppressant to suppress the abnormal cancer cells. Okay, so now the CML. Let us say someone developed this reciprocal translocation or Philadelphia chromosome, BCR ABL genes fused, and now there is increased activity of tyrosine kinase. So blast starts replicating. So how will they present? The clinical features of CML present in phases. So the first phase is chronic phase. 90 to 95% of the cases when they get diagnosed, they are in the chronic phase. In this chronic phase, mostly they are asymptomatic. They are asymptomatic. They may have some vague symptoms, means some fatigue, malaise, or sometimes they may develop splenomegaly. But otherwise, they're not specifically much symptomatic. Many of them get accidentally discovered as having CML, means someone does a complete blood count, peripheral smear, and then they start noticing abnormalities because there is increased proliferation of myeloblasts. So that leads to marked leukocytosis. So when someone sees high amount of WBC count, then they start investigating, sometimes as high as 1 lakh or higher. They start investigating and then they may come to the conclusion that, oh, this is a case of CML. But in terms of symptoms, they may not have any symptoms. But some of them, either at the time of presentation or eventually progress to what is called as accelerated phase. So what is this accelerated phase? See, chronic phase is a typical CML where patients have blasts which are less than 20%. And these blasts are not giving rise to any symptoms as of now. But if the blast starts increasing in number, we will get into this accelerated phase. In the accelerated phase, we diagnose it by presence of any one of the following parameters. What is it? WBC count more than 10K, platelet count less than 1 lakh, or sometimes platelet count more than 10 lakh, or more than 20% basophils, or development of massive splenomegaly, or blast cells in the marrow in the range of 10 to 19%, and patient not showing response to first generation TK. It may be confusing to you. I'll clarify. Just let me go through the points first. If any of these features appear, we will call it as accelerated phase. Okay. But then eventually some of these patients can go into what we call as blast crisis. So what is this blast crisis? Blast crisis refers to a patient of CML progressing to AML. That's as simple as that. A CML becomes AML, then it is called as blast crisis. How did we define AML? Myeloblast more than 20% in the marrow. CML less than 20%. But one day, if the blast either in the peripheral blood or bone marrow, if they become more than 20%, that is similar to AML, right? Then we will call it as CML going into blast crisis. Indirectly, CML progressing into AML. Or if you get extramedullary blasts, means blasts outside the marrow and the blood system, or the blood vessels, or the blood. Outside means in the tissues. And when blasts accumulate in the tissues, what do we call it as? Chloromas. So if you get any patient of CML with chloromas, it is considered as equivalent to AML, and we will call it as blast crisis. Okay. So now, how do I recognize CML? CML is recognized mostly they are in asymptomatic stage. When you get high WBC count, when they present with some vague symptoms, you get high WBC counts and you see that there is increased blast, but certainly not more than 20%. Then it is the CML with chronic phase. Now, when they are in chronic phase, we start treating them. What should be the treatment of CML? There is increased activity of tyrosine kinase, so I should treat them with tyrosine kinase blocker like Imatinib. Imatinib mesylate is considered as a drug of choice. Recently concluded FMG exam has a question on it. So once you give Imatinib, you expect these splenomegaly, blast cells to all settle down. They all should settle down. But if despite treatment, if their WBC count remains high, despite treatment, if their platelet count remains low or high, or their basophil counts, which are one of the end products of myeloid lineage, despite treatment, if their basophil count becomes high, or you have splenomegaly which is not shrinking despite treatment, the blasts in the peripheral blood or marrow remain more than 10%. See, if I had diagnosed it as a chronic phase and if I had started them on Imatinib, if they are responding, the blast should be less than 10%. If they remain more than 10% despite treatment, then it is accelerated phase. So they are not responding to the tyrosine kinase inhibitors, what we call as the first generation tyrosine kinase inhibitors. We are going to call it as accelerated phase. Now, eventually, if the blasts increase beyond this number and go more than 20%, or I start seeing accumulation of blasts in the peripheral tissues, that is chloromas, then we will call it as blast crisis, which is equivalent to AML, right? I hope now you understood. They present with some vague symptoms. Leukocytosis, the count may be even more than 1 lakh, the WBC count. And basophils high, all of these will be there. The hematological parameter abnormalities, that is your chronic phase. And you start them on first generation tyrosine kinase inhibitors. Expectation is all these things resolve. But if they fail to resolve and they continue to have WBC count more than 10K despite treatment, or platelet count low or high despite treatment, or basophils more than 20% despite treatment, splenomegaly persisting or progressing despite treatment, or blast remaining more than 10% up to 20% despite treatment, more than 20%, we will call it as blast crisis. Then we will call it as accelerated phase. From accelerated phase, if the blast increase to more than 20% or chloromas appear, then it is a blast crisis. Clear? Now let us look at how do we diagnose them. If you do complete blood count and peripheral smear, you will notice leukocytosis. The leukocyte count may be even more than 1 lakh per cubic millimeter at the time of presentation. But as I've already told you, with Imatinib, you're expecting it to come down to less than 10,000. When it doesn't come, it is accelerated phase. So blasts will be generally less than 20%. More than 20%, it is a crisis. You can have increased basophil count as well as eosinophil count, because all of these are derived from the myeloid lineage. And in the bone marrow, we are going to get hypercellular marrow, because there is increased production of myeloblast, but myeloblast percentage will be less than 20%. Less than 20%. If you want, you can make a note. If more than 20%, in a case of CML, we will call it as blast crisis. So this is the peripheral smear and marrow findings. What cytogenetic studies will show? You can either do PCR or fluorescent in situ hybridization to identify BCR ABL fusion gene. This is considered as the investigation of choice, because it can clearly prove that there is an underlying Philadelphia chromosome or BCR ABL fusion. Okay. So that's about our diagnosis. And once you have established the diagnosis of CML, how are we going to manage? So if it is a chronic phase where you have less than 20% blast, patients are not grossly symptomatic, but you have abnormal peripheral smear, bone marrow studies, and the the markers. In this case, you will start treating with the first generation tyrosine kinase inhibitors. Tyrosine kinase inhibitors. Examples for first generation tyrosine kinase, it is Imatinib mesylate. All the drugs that end with nib are tyrosine kinase inhibitors. Imatinib mesylate. So this is what I start. But despite starting this, if the blasts remain more than 10% up to 19%, or WBC count remains more than 10K, platelet less than 1 lakh or more than 10 lakh, basophils more than 20%, then it is accelerated phase. So once someone gets into accelerated phase, the first generation tyrosine kinase inhibitors are no longer considered suitable for treatment. So then we have to go for second generation or higher. So now we have third generation, they are preferred. So treatment will be with third generation tyrosine kinase inhibitors. These are more effective inhibitors of tyrosine kinase so that myeloblasts don't replicate uncontrollably. An example for this is Bosutinib. Okay, fair. If they respond to this, good. But if they don't, they will end up with what we call as blast crisis, where the number of blasts will jump from 19% to higher, 20, 25, 30, 35% higher. Once I get into the blast crisis, it is equivalent to AML, and we treat it just like how we treat AML. So treatment of AML in CML in blast crisis is similar to AML. How did we treat AML? We followed a 7-3 CD regimen, cytarabine, doxorubicin or daunorubicin based regimen, 7 days of cytarabine and 3 days of doxor or daunorubicin. Same thing, that is induction phase. Followed by that, we had a consolidation with cytarabine or the hematopoietic stem cell transplantation. Exactly same thing we are doing if patient ends up with blast crisis. If they respond to chronic phase, first generation tyrosine kinase inhibitors, well and good, beautiful. If not, if they get into accelerated phase, the third generation tyrosine kinase inhibitor like Bosutinib. But if they end up with a blast crisis, we treat it exactly how we treat a case of AML, right? So this is going to be our how we are going to approach the management of CML. So by these two questions, I hope you have got a gist of how we are going to write answers for the leukemias, and similar template will be followed for lymphomas. So key points you have to mention is keep in mind the basic pathophysiology, means exactly what is happening in these cancers. So in leukemias, the premature hematopoietic stem cells are replicating uncontrollably. In lymphomas, the mature blood cells, T lymphocytes, B lymphocytes, they are replicating uncontrollably. So lymphomas originate in the periphery, the lymphoreticular system. Leukemias originate in the bone marrow, but of course they can spread to the peripheral organs. And based on the leukemias, whether they're originating from lymphoblast or myeloblast, we will call them as myeloid leukemias and lymphoid leukemias. And based on percentage of blast cells, we will differentiate them as acute and chronic. So if more than 20% blast cells, it is acute. Less than 20, it is chronic. If it is lymphoid, then ALL, CLL. If it is myeloid, AML, CML. But all these malignancies have their own underlying cytogenetic abnormalities responsible for the cancer to develop. For example, translocation between 821 was one of the cytogenetic abnormality, mutation in NPML1 or FLT3 for AML. Then Philadelphia chromosome or fusion of BCR-ABL for CML. So if you remember these points, you will be able to replicate the answers. So to make it easier for you, on the note sheet, I will leave a table which compares all the hematological malignancies side by side. So if you kind of remember this table, then you can replicate the pattern of answer that we have discussed for the hematological malignancies, right? So that's it from me today. Today we have got a gist of how you will answer infectious disease questions. The simple template of answering infectious disease questions is try to remember the causative agent. If possible, try to write the route of transmission. And most importantly, please remember the natural course of illness and describe the clinical features under each phase, be it HIV, be it dengue, be it malaria, be it leptospirosis, be it enteric fever. And similarly, when you write about the diagnosis, make sure that you mention appropriate investigations according to the phase of the infection or the days after the infection. Like if I have to diagnose HIV in the acute HIV syndrome phase, only P24 or HIV PCR. After that, antibodies. Right? So similarly, if I have to diagnose dengue in first 4 days, only the antigen NS1. But after that, antibodies. So keep that in mind. For example, enteric fever, viral only after first 7 days. In the first after the first 7 days. In the first 7 days, viral test is not suitable. If you can do a serial monitoring, you can, but otherwise it's not suitable. So it is blood culture. So that is what teachers are specifically looking. They know, they will assess whether you know which investigation should be done on what day of a infection. And with respect to the treatment, mostly they are keen to see whether you write the drugs appropriately. You don't have to remember the dose. You don't have to even, if not possible, no need to write the duration. But the drug of choice should be mentioned. And the key pathophysiological manifestations. Like if you talk about HIV and respiratory system, pneumocystis carinii pneumonia, they are definitely looking for it. If you miss that, you lose some marks. And when it comes to hematological malignancies, they won't ask you to write a 10-mark essay on just AML or just CML or just ALL or just CLL or NHL. It will be part of a longer question asking you to write more things like classification of hematological malignancies or defining leukemias, and then also asking you to write a short note on the tumor lysis syndrome. So all you need to know for writing the hematological malignancies is what is the cytogenetic abnormality, what is the key pathology. Like in AML, increased myeloblasts in the marrow more than 20%. CML, increased myeloblasts in the marrow less than 20%. ALL, increased myeloblast, lymphoblast more than 20%. CLL, increased lymphoblast but less than 20%. Non-Hodgkin's lymphoma and Hodgkin's lymphoma originating from the mature B or T lymphocytes, not from the premature cells in the marrow. So if you are able to write these key points in the definition or introduction, that opens the answer very well. Remaining points that you need to write, it is there in this table. So just by heart the table and you will be sorted for writing a 10-mark question on hematological malignancies. So that's it from me today. I'll be signing up because okay. So why viral is not done? See, the titer reaches. Okay, there are two, three things you need to remember. Viral is one of the extremely misused, abused test by coax and nowadays even MBBS doctors. So when you get infected with enteric fever, you have this bacteremia. The bacteria are now circulating in the blood for initial 1 week or so. Okay. After that, the antigens reach a load of detectable value. And then that's why we need to do it after 7 days. Before 7 days, if you do vital, if it is a non-endemic zone, it will come negative. And if it is endemic zone, even when you don't have enteric fever, you may have higher titers because you would have got some exposure and you will have higher titers and it may still come positive. So in country like India, which is endemic for enteric fever, you will have higher titers even in the first week of fever. Ideally, you should not have higher titers in the first week of fever. The titers will be higher in the significantly higher in the second week. But in endemic countries, it will be higher in the first week. So if you go by the standard cutoff, any patient with any fever will turn out positive in the first week of fever. So you will label everyone as enteric fever, and that is what happens when you see in the practice. You go to any quack or a non-modern medicine doctor with fever. On day 2, day 3, they do vital. They get some higher titer and they label it as enteric fever. Give antibiotics. So they use it as a license to give antibiotics. If you want to use vital test in within 7 days for the diagnosis, as I've already told you, India is endemic, so all of us have titers higher than what is seen in the non-endemic region or Western world. So if you are following the Western cutoff, invariably, even if I'm having dengue, my titer will be positive. So the best way, if you want to use it in the first week, is have a rising titer. Like do a titer on day 2, do a titer on day 4 or day 6, and then you see that the titer is rising, then you can use it as a diagnostic for enteric fever. But more convenient way to diagnose in the first week would be rather go for the blood culture. If blood culture detects, you know you have enteric fever. And second week, if it is positive, and again, the interpretation of vital is that I can't give you a standard number. So say that if titer is 1:40, 1:80, or 1:160, I can call it as positive, because you need to be aware of locally prevalent general population titer. And only when the titer is higher than that, then you can count it as positive. So if I'm practicing in Karnataka, Bangalore, I should know what is considered as a normal vital titer in general population. And when it is higher than that, then it is positive. And the normal titer of this population may be higher than the Western standards that we study in the books. So that's why vital is a bit of a cumbersome, complex test to interpret in real practice. So that's why, like if I get a patient with fever, I would certainly investigate in the first week itself. And if I'm going with the investigation in the first week, it's the blood culture, which is the investigation of choice. Okay. So that's it from me today. I'll be signing off. The notes will have this table so that your hematological malignancies are sorted. And anyway, the Farre section in the MEDED written notes has all the hematological malignancies covered. So don't miss out on covering them as well. We will connect in the next class and we will discuss other important sections. See you soon, guys. Good night.